So without wasting any time, so as we know the basic history, in 1900, first time he observed, or you can invented the interferometer, and which is a basic science again about the optical coherence tomography. And David Huang was the first to use in vivo imaging in 1990s in the form of time domain. You'll be surprised to know that OCT was first used in the vascular surgery area, not in ophthalmology. And because we are in a lucky specialty that everything is optically accessible, so any new gadget which comes over, we are entitled and we are using, and to a great effect to our advantage. The first commercial domain came in 1996. There's a time domain OCT, we all know. It was, again, at that time, it was a revolution. Nowadays, we have a lot of reservation about this machine, but we have all started our introduction to the OCT with this time domain. And at that time, it appeared such a good thing and a great thing to us. And it's a great relief in managing our ARMD patients. Before that, we were depending on the fluorescein angiography. And there are a lot of, say, terminologies which are getting confused, and we didn't know when to treat, when not to treat, when to stop. Subsequently, the time domain made a big difference. SD OCT was again a big change, and it made the job so easier, undilated pupil, very fast recording, and more objective. Particularly the glaucoma management became, observation became, I will not say the management part, but became much easier as compared to time domain. So this is how what the OCT has made. Like you have a multi-floor housing societies, so it made our retina to appear like that. We are able to discern the different layers, layer by layer, and you could really pinpoint the diagnosis and the pathology. So this is just giving a background how the investigation has evolved from the MRI from 1 millimeter to now with a confocal at 1 micrometer. In between, we have that conventional OCT of 10 micrometer resolution. So this is all the, say, new thing coming up gradually, and possibly in due course of time, we will have almost histopathological picture with the new machines. So it's a non-invasive, non-contact technology and based on low coherence interferometry. So it's just giving a idea about the general foveal dip that we all know, the nerve fiber layer. Basically, the color that we see is a pseudo color. Normally, the OCT, basic OCT is in black and white, and it is just a pseudo color generated so that we are able to read it much more easily and possibly with a faster rate. I will not go into detail about this. Basically, you have a reference beam and measurement beam. It's something like that you can think of an ultrasound. Only thing that here the reference thing is a light noise instead of the sound beam. And this is a small comparison that we have this Cirrus OCT and the time domain OCT that we have. This is something aircrafts that used to wobble around when you travel, and now we have a smooth ride all along. And one of the best things that could have happened with this Cirrus OCT, spectral domain OCT, that ISOS junction. As a retinal surgeon, many times we were confused that I have done a good job, the retina is settled, but why the patient is not having good vision. Subsequently, when this came up, then we were able to know that the ISOS junction is compromised and patient may not get a very good vision. And you can explain to the patient what's gone wrong without blaming yourself. So again, this is a comparison between these two, the Cirrus and the spectral domain and the time domain. The resolution has become better, particularly the small pupil and non-cooperative patient, it has a big boon. In time domain, we will have to dilate the pupil. The patient has to be reasonably cooperative to get a good picture. Of course, now much more and many more companies have come up. This Cirrus OCT from the Carl Zeiss, Spectralis, Heidelberg, 3D OCT from Topcon, and RTView, OptoView. Some of the Korean companies also come up, and Indian companies are also coming up with this machine. This is just a routine picture that you see on OCT, different layers. You can really discern and really understand what's going on with the patient. So coming to the usage, of course, the maximum use in the retina, we have in diagnosis, in treatment and follow-up. Neuroophthalmology also is a big help, particularly benign intraocular hypertension, where we can objectivize the thickness of the nerve fiber layer and the optic nerve head and tell your neurology patients, colleague, that when the treatment needs to be stopped. And when sometimes you can get confused whether there is a edema or not, this will give a very clear-cut picture that patient may be just having a normal optic disc. And of course, anterior segment, which is beyond our scope in this session. So common causes of abnormal reflectivity on optical coherence tomography. It is, so you have hard exudates and calcification. It is something same like in ultrasound. If you go compare it, then the blood and the scar and fibroid lesion, they will have a higher reflectivity, a more deeper color, the ERM that we all see very commonly these days. So sometimes the OCT reads more than actually what is there. So particularly the ERM will come later, that it may not be affecting the vision, that it's because of the presence of ERM. So very careful, just don't be over-trigger happy to advise surgery in these patients. So hypo will be a fluid, the retinal edema, subretinal fluid, sub-RP loss, and loss of tissue. This is again showing a different type of modalities that we use while using the optical coherence tomography. You get a good picture where we are getting the cut section. Coming to the vitreous, the vitreoretinal interface is very important. The foveal contour, if the foveal contour is disturbed, you may not expect that good vision. And of course, the intraretinal presence of fluid and RP and choroidal complex is again another area that we all go through. Coming to the vitreous, if you have a vitreous hemorrhage or floaters, it may not make a full entry into the up to the retina. The asteroid hyalosis again will give you something like a dropping, say, drops in the vitreous cavity, and other floaters also will give you reflectivity, which you can see on the OCT. This is just showing on the right side that you have that asteroid hyalosis picture. Coming to the vitreous and pre-retinal abnormalities, again, it's very important that you should analyze the thing with the clinical perspective, that what is important, what is not important in the vitreoretinal interface, which Dr. Anil will be discussing in detail. So vitreomacular traction in ERM. When there is a vitreomacular traction in ERM, always take into consideration the level of visual acuity and level of difficulty that the patient is having. If the vision is good, if there is no metamorphopsia, you can just keep the patient under observation. So this is a very classical picture that we many times see, and of course this patient will need surgical intervention for visual improvement. Coming to the relationship of the relational membrane of the retina and assessment of retinal thickness, the two patterns are very important, the focally adherent and globally adherent. Very commonly we see the globally adherent ERM. In those cases, we may not do anything. If there is a focally adherent and if there is a traction on that particular area and disturbing the vision, you can think of surgical intervention. This is the globally adherent ERM. Of course, these are the retinal conditions where may not be very useful directly as a diagnostic part, but definitely when you diagnose the diabetic edema or the edema due to urinary gas syndrome, it gives a very fairly good idea of the cause of the drop in vision and how the patient is responding to treatment. The macular hole, of course, is the laminar hole. This is a very, very important investigation that we have removed doubt. Many times you think it is a macular hole, full thickness, but it's basically a laminar hole, and you can hold your hand and don't do any surgery. Juxtafoveal telangiectasia is another condition where this OCT has been of a great help in helping us in diagnosis. So this is, of course, the BRVO. The one classical picture in BRVO is that you have a, say, hemiretinal type of edema, so that you can, even just seeing the OCT, you can make a diagnosis of BRVO. And CRVO, of course, will have full thickness and DME and CME, of course, we all see day in and day out and treat accordingly. The macular hole, of course, the diagnosis and staging, the associated ERM, the surrounding retina, cystoid changes, and elevation of lips. And here we can all go that objectively analyze the possibility of success after surgery and explain to the patient. And the follow-up, of course, you can do very, very regularly and routinely with a great effect to the patient's satisfaction. This is, of course, everybody can make a diagnosis of the full thickness macular hole. This is a laminar hole, and these patients may not need surgical intervention unless the vision is very compromisingly low. This is one situation I would like to discuss. This is juxtafoveal telangiectasia. Here there is no edema. This is not edema. Many times even we have injected, I think, in the past, long back, of course, thinking that it is a macular edema or some fluid because of some pathology, but basically it's a tissue loss and nothing needs to be done in these patients. Coming to the age-related macular degeneration, where it made the big difference. Of course, you can pick up the drusen geographic atrophy, but the main part where we were held is the choroidal neovascular membrane and the presence of subretinal fluid, which decides whether the further need of injection is there or not. Again, there's one condition that I will like to mention is This is, of course, the different types of CNVM that we all know, and we need not repeat it again. And of course, if there is a disciform scar already, but if there is a fluid, and if the patient is willing, and if you feel that vision might improve a bit, you can discuss with the patient and inject, but these patients may not do that well. Of course, geographic atrophy, we don't have right now any clear-cut answer. And this is, of course, after the treatment. It's, I think, well-reviewed photographs, and this is a real great thing which has happened. And this is one thing I like to again CNV with myopic degeneration. In myopes, you may not see fluid present, but if there is, you can see the complex. I think you can inject, and the patients do very well. And vitelliform dystrophy, many times you can get confused that this could be a complex, but actually it is not. If you look carefully, there is no fluid presence, there is no edema. So these are the patients just need to be observed and nothing to be done. And of course, PCV is a very difficult situation where possibly the indocyanine green angiography is much more useful in helping us in diagnosis. But still, you can make out with the OCT some markers, the notch and all those type, a thumbnail appearance, everything is there in this picture. And these are the conditions where you have to decide what type of the anti-VEGF they will be using. The newer ones are more effective as compared to the ranibizumab. And you can go with the aflibercept or even Vabysmo, that is a new drug which has come in the market. And CSR, it is a big change that we don't need to do a fluorescein angiography or invasive procedure, and you can diagnose very easily with one go with the OCT and tell the patient about the reasonably good prognosis in these patients. Only thing that you should be careful when you are diagnosing CSR, particularly who are not practicing retina, that you must have the two ages well defined. If the one age you are not able to find the end, be careful, you might not be missing an inferior retinal detachment. So in one thing that we have observed in diabetic maculopathy, you may not have a full drying. You have to really see if the vision becomes stable, it's not improving, not deteriorating, you can just hold your hand. In AMD, we have the different type of regime available. Treat and extend is possibly the most scientific and most effective. And here you aim for a total dryness. In diabetic, you should never aim for total dryness because possibly you will never achieve that in most of the situations. And of course, unexplained visual loss, look for foveal atrophy, disruption of ISOS junction that I discussed, and subtle serous detachment. Many times you have done a good retinal detachment surgery and patient is not improving. Once you do an OCT, you find a very minimal serous detachment present. So you can explain those patients. You might give some steroids, PST, or maybe even intravitreal to help these patients. So thank you very much. Now I will invite Dr. Anil Solanki to present. You will present Octa. Okay. I think Dr. Puneet will be presenting the Octa, and then we'll move on to the vitreoretinal interface. I would like Dr. Amit to pass few comments.
So now OCT has become an essential part of everybody's practice. It's not a domain of a retina, glaucoma, or neuro-ophtha. I think everybody, as the cost goes down, it will become a regular tool in everybody's practice. Whether maximum in a high volume retina practice, cataract practice, where they look for the fovea before they do a multifocal or a toric.